Oops, I'm on the wrong agenda item. Sorry. There we go. Next up is the chairman's report. We do have, actually, I would ask each of you to please take a moment to review the attendance, which is attachment 3A. If you have missed more than 2 meetings, the Bureau will reach out to you to see if you want to continue to participate. We do appreciate all of you that do participate on a regular basis. Thank you so much. We do have, I believe this is actually 1 vacancy. I believe, Shelley, correct me if I'm wrong, we have filled the Sames seat. I believe that's our new member today. And we have 1 open one, but Shelley, can you please clarify for me which open positions we have, just so I'm not misrepresenting?
Sure. Received a resignation from Garth Gamer, so the EMS medical director of a premier EMS agency is vacant, and then there's a Sames role available, the pre-hospital EMS coordinator.
Perfect, thank you. If you are interested in the Sames one, please email the executive director, Sarah Parati. And for the Premier EMS Agency Medical Director, should they reach out to you, Shelley? Is that correct?
That's correct. I put on the agenda to apply for a role that's not aligned with the region. They can send a letter of interest and resume to me, and my email address is on the agenda.
Excellent, perfect. Next up, we do have 2 members present today. Meredith, do you want to take a moment to introduce yourself?
Hi there. Yes, thank you for having me. Thank you for this appointment. I'm Meredith Radowski. I'm the trauma program manager at Chandler Regional Medical Center. I've been in this role about 5 years actually, and with trauma services for 8. Happy to be here and answer any questions about myself that you may have.
Perfect. Welcome, Meredith. Thank you for taking part in our committee. Next up, Joe Galata.
Hey, everybody. Thank you so much for having me. My name is Joe Galata. I'm a data analyst for Northwest Fire District in Marana, Arizona. Been here for about 1.5 years. Before this, I worked as an EMT for almost 8 years with AMR. So excited to be here and looking forward to this.
Excellent. Welcome, Joe. Last but not least, take a moment to check out the meeting schedule for 2026. It is available at the link on the agenda. I won't take time to go over it bullet by bullet. That ends the chairman's report. With that, I'll turn it over to the Bureau staff for the Bureau report.
Okay. Hi, everyone. Hopefully you can hear me. I'm Nicole Witt, Assistant Director. I'm a very poor Bureau report person, so what I missed, I'm sure others will jump in, but I did want to start off with acknowledging Chris Hale, who's joined us today here in person. He is our new Bureau Chief for the Bureau of EMS and Trauma Systems. Chris just this week, thrown right in with today. We're excited on board. Chris has been with our agency for more than a decade in leadership roles. He's been a public servant for, won't age you, but several decades, including both at he started when he was 2. At state and federal levels. So we're just really excited to have his expertise and help us with all the processes and work that we need to do in the Bureau. You'll hear less from me, which I'm sure you're all happy about. So anyway, I just want to say a huge welcome. And Chris, I don't know if you want to say anything, put you on the spot, but.
Thank you, Nicole. I'm just glad to be here and being a part of EMS and trauma. Look forward to working with all of you and helping us do what we do great to help save lives in Arizona.
So Chris will be making the rounds. We'll have already started to set up meetings with various stakeholders. So if you are interested, definitely reach out and we'll start filling his calendar up for sure. Also, before I just want to acknowledge attachment 4B is the actual Bureau report. Do want to acknowledge another new staff member, Savannah, who you'll see a lot more of today. So Savannah is our new EMS for Children coordinator. Also has been with the agency for a number of years. We stole her from the prevention division, so we're really excited to have her expertise in that role. And then we do have a couple of vacancies as well. So we're currently recruiting for a program project specialist. And that is open on our website. We have lost some staff members in our DON section as well. And so we will have some postings in that area as well. So we'll keep you updated on those vacancies and what's to come there as well. There's a couple of items on here. I'll probably ask Julia to help out. Just a few reminders on the EMCT certification. I'm sure Gail will want to jump in. We do email 30, 60, and 90-day reminders to individuals. So really do as much hand holding as you can to make sure that people get in their application. We are seeing a lot of past due. So individuals, EMCTs who are operating uncertified or not getting their application in on time. So really just a real reminder for everyone. We're doing what we can to make sure that those reminders get out there, but certainly can use the support in that regard. And I don't know if you can add anything, Dr. Bradley.
No, I think the big thing just to remind everyone is that the email address is a .com versus a .gov. So when your EMCTs get their renewal notification, just to make sure that they check their spam folder, just with the image trend system that did transition to a new email address it's coming from. The email address that each individual uses to register is where that notification goes. So the 90, 60, 30-day reminder. And we've just, as Nicole mentioned, seen an increase in the number of individuals who've been working with expired certifications. So the process hasn't changed, but it just seems to be something we need to remind people of, is that reminder will go out specifically to the email address that they are registered with the state.
Also on here is just some upcoming changes to the Trauma Center Site Reviewer. I am not the best to answer questions about that, but I'm looking at Julia across the table, who is a little bit better on our process, but we are moving to an RFP process. There's just some changes. I think there's great information on the handout that you can orient yourselves to why that's happening, and we're always happy to answer questions on that. I'm going to turn it over to Gail.
Okay.
And she always does a much better job of giving her update on our blocks and leave on it.
Okay, excellent. So several of the data items we will discuss later on the agenda, so I will skip those for now. But just wanted to point out in the packet, you can see there the update for naloxone leave behind. Really incredible that we have 68 EMS agencies across the state. We do have a map that actually demonstrates we have a really nice distribution of both urban and rural agencies across the entire state of Arizona. And as you can see there, we have just over 4,700 EMCTs trained, about 7,500 kits that have been shipped. And what we are really excited is the number now that we're seeing of actual kits that are scanned. So we really appreciate all the agencies working with your personnel to scan those kits. So we're at a third of those kits now being scanned when they're given out in the community. So a big thank you to everyone's support of this. We know that there's a lot of work to do in Arizona regarding opioid overdoses, and we do feel that this is a big part of that response. So thank you for everyone who has supported that. Can you quickly click on that map just so we can show everyone? I think it's a nice, this was a request that someone had asked at one of our previous meetings. So we have a great data and GIS team that could put this together. And you can see here kind of the distribution on the map, and you can see really nice across the state of Arizona where we have the agencies participating. The other data pieces, like I said, we will mention further down on the agenda. We do have some just who do I contact that we keep on here. We do get questions sometimes of, is there a person I can speak to if I have a question regarding enforcement or certification? And so we did include both the FAQ section as well as telephone numbers and links to the website. So if you have a question and you want to speak to someone directly, that is available for you to click on as well.
Just one last maybe update from the more the agency that it's not listed in here, but I'll just highlight. I think we did share out, there is the Rural Health Transformation Fund that our governor's office was the lead for submitting for that grant for the state of Arizona. That is public, so you can see what the governor's office submitted. There's some really great items specific to EMS, the EMS and trauma system within that grant submission. The total submission that was submitted for Arizona was $200 million. I don't know that we will be funded for that full amount, but the larger buckets are really around healthcare innovation, a huge amount related to workforce. And so thank you all. I know Julia did a little bit of work, and David, to reach out to our regional coordinating councils to sort of identify what's most important for for all of you in rural areas as it relates to workforce development. So those we did ensure that those were included within that consideration and application. So some really exciting things on the forefront. There's also some in the proposal funding related to maternal child health outcomes in rural areas, and also chronic disease prevention, including cardiac arrest. So very important things. And then under the health innovation, I think there were some pilots in there related to EMS pre-hospital care as well. So anyway, that'll we'll make sure if that hasn't already gone out, but I think it is public, so we can share that link as well. So you can read the full submission, and we'll keep you updated on that as get worded. That's it.
All right, I think that is it from the Bureau, Josh.
Excellent. Thank you for the update, everyone. Next, we move to updates from our subcommittees. First up, the Trauma Registry User Group. Maria.
Good morning. Can you hear me?
Yes.
Yes.
Okay. On our last truck meeting, we went over our new changes for 2026 for NTDB. Carissa also went over our submission that is due January 2nd, and she said she will review it once she comes back from maternity leave, the first or second week of January. She also had 3 trauma hospitals go over the trauma register workflow, and that went well. And she also wanted to remind everybody that we could share reports on the new system on ESO. That we're only sharing the report. There is no patient information being shared if you opt in to share those reports. I think that's it, that we went the most important thing.
Josh, you're on mute.
Sorry about that. Thank you so much, both of you. Thanks, Maria, for the update. Any questions for Trug? Great. Next, moving to Trauma Program Manager Workshop. Heather.
Yes, thank you, Josh. So we had our trauma program manager workshop on October 3rd at Summit Healthcare. Lots of good updates from the Bureau, as well as rural trauma review with EMS, talking about some over and under triaging, addressing some of the blood wastage in our massive transfusion protocols, and some just trauma 101 inspections and frequent findings and fixes. So our next trauma program managers workshop is on January 23rd at Chandler Regional, and we're working on the agenda.
Excellent. Thank you, Heather. Any questions for Heather? All right, moving right along. Ray, updates from the EMS RUG group.
I don't think that Ray is on the line. I don't know, Anne, I think you are on if you're able to give that update, maybe.
Okay, I'm so glad I found my agenda. I thought to myself, I'm like, oh, I should be ready. Because of course it's been 2 months and I deleted that from my brain. So we actually had a really interesting EMS Register Users Group. If you want to listen to the recording of it in the minutes, they are available online. So I'm just gonna basically say we went over some really interesting discussion with Dr. Rice and a few other individuals regarding Gail, the blood glucose validation rules and some tweaks to those, which were after the meeting, they have been completed and have been rolled out in the new schematron. We focused on some data quality issues, including we really need to try to focus on getting better documentation of initial patient acuity and final patient acuity, which is also called acuity upon EMS release. Those are used in a lot of areas, but especially we've noticed this in our new cardiac arrest and share reports, that it's critical for us to understand whether or not the patient was viable. And we also would like to emphasize the documentation of delays, because we do use that information. So we had kind of a few focuses there. And then as far as any other highlights, we did discuss some recommended new codes that have come out fairly recently for tracking. And this actually came out of, I think, was it the STAB meeting from last time, a recommendation for e-bikes versus e-scooters and segways that are more specific to those particular cause of injury. So I've added those to our system. We've also brought it up nationally. So we're going to have a discussion with BEMSTS about adding that to their defined list. And I believe the trauma registry has also updated or will be updating their codes. So that's kind of exciting because I know everyone's interested in kind of trying to track that a little bit more clearly. And then I took some feedback on some reports that I'm actually going to discuss later in this meeting. So I think that's the gist of it.
Thank you, Anne. Great update. Questions for the EMS rep? Excuse me. Great. Moving on then. Next up are our discussion and action items. The first item is to review, amend, and approve the meeting minutes from our last meeting. I will look for a motion to do so and a second if someone is willing.
Motion to approve.
Thank you,
Second.
Michelle.
Second.
Thank you, Heather. All right, now that we have a motion to approve, any discussion or requested amendments to the meeting minutes that are before you now? All right, I hear no discussion. I'll give you 5 more seconds, only because in this virtual environment, it can be hard.
Josh, we have no TEPI members in the room to worry about.
Copy. All right, then in that case, I'm going to call for a vote. All those in favor of approving the meeting minutes as presented, please say aye.
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 Any opposed, say nay. And any who wish to abstain, say aye. Thank you all. Hearing no abstentions or nay votes, we'll consider the meeting minutes approved as presented without amendments. Thank you very much. Next up, we're going to go on to the data visualization for offload times. Dr. Bradley, I'm going to guess someone on your team is going to share this a really cool dashboard that I actually used yesterday.
Absolutely. So this was Matt Shaw, who is in the room. You can thank him for this. This was a request that we put this out. And really, I think kind of aligns with a lot of the work group activities that started in Southern Arizona and then kind of extended to the central region as well, looking at offload times. One of the pieces that I did want to point out when you look at this data, because we've gotten some feedback from agencies that said, well, you know, our data, our offload times are longer. So this is county level data. So within a county, especially the larger counties, you may have areas of a county where your offload times are longer. Where this can be helpful is I think you can then work with your hospital partners as an EMS agency to say, if for our county level data, this is the average or mean offload time, if you are well outside that for your kind of catchment hospitals, I think this is nice data that you can show in comparison when you're trying to figure out how things are looking. So as you can see here, we did include both 911 and interfacility, and you can see some pretty significant variation here in terms of those times. The good thing is really across the state, the vast majority of patients are offloaded in a short amount of time. We do realize though that as an EMS agency, if you have even a few patients where you have really prolonged offload times, that does impact your ability to respond to your next call and have units out of service longer. So these are great ideas. We really appreciate the feedback that we get from you as stakeholders because we have a vast amount of resources. Vatzel and Anne and the entire data team really can kind of utilize the data you input with your crews into AZ peers and produce these reports. So we wanted to just highlight this. Glad to hear, Josh, that you utilized this data yesterday, and I think it is helpful. But do want to point out, again, this is county level data. So if you feel like for your agency it doesn't reflect that, that is something that you can then kind of use in comparison because it's going across the entire county. Any questions about this?
Thanks to all of you. This is really cool. I will give you my one comment. It would be super helpful if we had a key to the colors. It took me a long time to figure out what the different colors meant on your map there because they don't correspond with the colors above. So adding in a key would be super helpful if you're looking for suggestions.
No, that is a great suggestion.
Any other comments, questions? encourage everyone to play with this. When you hover over the state, it tells you kind of the data down below. So really kind of fun to play with and a valuable tool for everyone.
Maybe come closer just so I can hear online. Thank you.
Yeah, I think this is awesome, and I'm really excited for that Vatsal and Ann did so much work on this. I think like nationally, this is not something that's tracked, and there is no national definition of offload time. And so the state creating this definition, or at least standardizing it, is really helpful as far as agencies tracking their specific offload times. Because like you said, this is county level data, not agency specific data. So there might be differences, but this gives everyone a really good like jumping off point on like how to measure it. So I think this is great.
I will just add, it's a good suggestion, and certainly we are bringing it up and looking at it. We have a responsibility as well as ESFA to look at, over the course of the year, we're entering into respiratory season. And so these are system level indicators that are important. And we do look at a county level. That's how that system works. So it has a separate function for us, broadly speaking, for the health of healthcare system too. So yeah.
And I think one of the questions we had gotten was, if you can maybe scroll up, I believe this is 2024 data. Yes, so I know that they are, the data team is currently working on making this a little bit more real time. There's a few issues kind of on the background on the data side of things, but we do anticipate moving forward. I hope I'm not misspeaking, Vatsal, because I think she said that it is possible that this will become not necessarily fully real time, but much closer to real time to be able to track some of that syndromic surveillance.
Great, thank you all. Other questions on this before we move to our next agenda item?
Okay, thank you, Vatsal, for the thumbs up.
Excellent. Thank you again for that work. Next up on the agenda is to discuss the SHARE program update. Adam?
Sure. Hi, everybody. My updates are items D and E, so I'll just kind of cover them if that's okay. I'll try for us. Yeah. So, on that first link, the cardiac arrest dashboard. So this is what's replacing our cardiac arrest report year over year. Previous to 2024, they've been static PDFs. So from 2023 and previous, they were static yearly PDFs produced. Going forward, this is the format which we will. So this is what the aggregate state annual report looks like. There at the top, you see our total 11,741. That was the total amount of cardiac arrests. So I'm going to walk through this quickly for the EMS agencies because the EMS agencies have recently received their own agency-specific SHARE report, and it coincides. It's formatted the same as the aggregate report. So I'll run through the aggregate report.
Can you just clarify that it is the total number of cardiac arrests that are in SHARE that we have? Because there are some discrepancies.
Okay.
So just want to clarify that.
Thank you. Okay, so out of that 11,741, a nice round number, 5,000 were immediately excluded for DNRs, no resuscitation or final disposition was incomplete. From that, subtracting that 5,000, we have 6,741 cases as entered by EMS agencies and AZ peers. Coming off to the left of that, 2,394 were EMS termination of resuscitation. So that person never made it to the hospital. Underneath is transported to hospital. So 4,347 plus what was terminated on scene adds up to 6,741. So 4,347 made it to the hospital. The ideal SHARE pathway would be if they were transported by an EMS agency participating peers, they were transported to a hospital, and that hospital was a CRC hospital. So below you see two sets of boxes that are transport to the hospital, one representing the amount of transports that went to cardiac receiving or referral centers, and the other representing the amount that did not go to cardiac receiving or referral centers. We can still get the outcome population if that patient didn't follow the ideal pathway of going from an AZ peers EMS agency to a cardiac receiving or referral facility with outcome data. We can find outcome data available in the ePCR. So if a patient does not get transported to a cardiac receiving center, we were able to find a number of outcomes in the ePCR. So transported to hospital is the sum of 4,347. So 3,300 went to a CRC and 1,000 did not. Of that 1,000 did not, we were able to find 321 with an outcome. Of the 3,340 that did go to a CRC, we see that we were able to find outcomes even if the outcome was received after linkage. And so we were able to find outcomes in the PCR on both sides of our pathways and as well as the ideal share pathway. And so the total number of included patients is 4,970. Jumping forward just a little bit. This is the summary page. This is the number of EMS. Oh, sorry, Dr. Baker, I see your hand up.
Adam, can you go back for just one slide? I had a question. I apologize. I was curious. Okay, I see. So I was wondering how you this number 4,347 includes those patients that were termination of resuscitation, right?
No, sir. The 4,347 was the amount that were taken to the hospital. The number above it, 6,741. If you see the red line off to the side and then pointing down, the 2,394 was the amount of EMS termination of resuscitations.
So I think therein lies my question. Are these patients on the left there, EMS termination of resuscitation, patients who were declared dead and resuscitation was not attempted, or only those in which resuscitation was attempted?
Those are ones where resuscitation was attempted. So the exclusion at the very top. So if you look at the very top section there, the total cardiac arrest that we have recorded in AZ peers, anyone who no resuscitation, that's a pretty significant number. You can see excluded there about 4,500. And then DNR is a pretty tiny number. So those are the majority of the exclusions. So then when you scroll down, that 2,394 is the ones where EMS did start resuscitation and then field termination.
Excellent. Thank you for that clarification.
Okay, the summary page, this is the number of hospitals and EMS agencies that we use to derive this data. So we have 173 agencies participating in share and 40 hospitals participating in share. There's that shared population number again, 6,741. And when we look at who all has outcomes with that, we have 4,970. Below them, we have the outcomes from both the field and the final outcome. So the field outcome is 64% of the time they were transported to the hospital, and then 35% that was termination of resuscitation. And then over here, the final outcome, 48% of was EMS termination and resuscitation, 46% died in the hospital, and a small percent of survivors. The UDSTEAM population was included for both the field and the final outcome. That UDSTEAM population is defined as a witnessed arrest in a shockable rhythm with someone who does not have a DNR, meaning I think it means the most viable population possible. And so that's what these two numbers represent, 698, 461. Okay, the next is demographics. This is how the report slices up different categories of our included population. You can click through that and hover over things.
So, and Josh, I'm assuming, sorry to go back to that, your comment regarding the colors on the map, it would be helpful to have there as well. So I think that
Super
is
helpful, yeah.
Vatzel, is that something that can be added just because I know you're online?
Yeah, I think I can put the legend which can show like which color is the minimum to which towards it is moving towards the maximum or higher side.
Thank you.
Use your field characteristics out of that 6,741. This is an important portion of it because it identifies a very important aspect of the SHARE program, which is bystander intervention and AED use. And so we have a total percentage of all those that are willing to give CPR, and then we have the breakdown of who is getting those that CPR, and most often it's a layperson family member, a medical provider, perhaps a law enforcement officer. We've decided that LEOs should have their own category because they perform it so often. And then the rest you can see there. Median response times, ROSC rates, and AED application rates are also represented on this page.
And one of the pieces, I think, as we look kind of across the state, where can we improve survival from out of hospital cardiac arrest? There's a couple key elements. Number one, when we see that really under 40% of all patients get CPR prior to EMS arrival on scene. And so we do know that there's zero chance of survival. If bystander CPR is not performed, that patient has no chance of survival, unfortunately. So really some of our interventions, how can we address increasing that bystander CPR rate? Also AED application. For each minute that you wait to apply an AED or defibrillate someone in VF, your survival drops about 10%. So if no AED is applied and we have a median response time of 7 minutes across the state, you've already dropped your survival rates by about 70%. So when we look at what are things that we can do to improve survival, certainly some of these things are really factors that we can try to improve. You know, how do we get more AEDs in the community? How do we get people to utilize them? It's a scary device for a lot of people, but honestly, they're designed to be very easy to apply and utilize. And so when we look at kind of how do we improve survival, these are some of our big interventions we can target. Yes.
Do you track broadly where the cardiac arrest occurs? That was
I think that is a metric that is tracked, but I would probably let Ann or Vatsal speak more to that if they're online. The question was, do we track exactly where the cardiac arrest occurs, meaning in the home or in public places or what have you? Vatsal, can you answer that, or Ann?
Yes, we do collect that information. We do have a location. I can try to see, you know, how well that is captured, and if it is, then we can add to the dashboard.
Yeah, great suggestion. And certainly if someone's in a public place where there is potentially an AED available, that would be helpful.
Yeah, we can do that.
Number increases in public places, whether it's willingness to use agent or lack of equipment.
Yeah, great suggestion. Thank you.
And the final tab is final outcome. And so these are the final outcome numbers for things like shockable rhythms, bystander CPR, your Letstein population, response times, CPC scales if they were discharged. And when in the upper left, you can toggle the years 2023, 2024, 2024, 25. Again, prior to this, you're going to see static PDFs that were produced annually. So this is what the EMS report is going to look like. Sorry.
Can you scroll down just a little bit to response times there? So this was something that had been requested actually by a member from STAB when we demonstrated this initial report, because really what they said as an agency who responds, they wanted to know kind of if you start breaking down into smaller incremental times of response times, you know, what does that look like? So kind of looking in terms of what are the response times like, understanding that each minute is so critical. And so if you look at about 21% get a response by EMS in 0 to 4 minutes, 5 to 8 minutes, you jump up to 47%. And then when you go to the 9 to 12 minute mark, that time frame really, if no resuscitation is being done by anyone, that patient has essentially no chance of survival. So as we look at, you know, agencies had said they want data to demonstrate why they may potentially need more resources, and the resources, if you start breaking down into these incremental times a little bit more closely, demonstrates kind of what % of the time is a patient getting an EMS response for potential resuscitation.
So this is the same format as what you will receive, or what you already have received as recently as last Friday in your EMS individual agency report. If you would like a copy of that, please reach out to us, or I think I'll drop a link in the chat. We do ask that you use a work email to make that request. If your agency doesn't give you a work email for some reason, just reach out to us and we'll find a way to get it for you. We just want to make sure that this information is, when it's agency specific, is indeed protected and going to the right people. That's what I've had for the share update.
Yeah. And when you request your agency level report, we did get initially some people that had some pre-hospital coordinators had requested it. That's something you can certainly work with your agencies that are based with you, but we can't give an agency specific data to a hospital. We really need you to make sure that that is coming. Once you as an agency get your report, you can share it with whomever you would like. So I know a lot of agencies share this up to kind of a city council level and utilize that, but we want to make sure that we're not sharing data with people that may not be the right ones to get it. So we don't know if you use a Gmail address, which we've got quite a few Gmail addresses submitted for reports. If you leave an agency, we don't know that. And so we don't want to share a report with you in the future and you're no longer associated with the agency. So that is why we've asked, really make sure you're using an agency specific address. If you do not have an email address, that agency can work with you. There's a few tiny rural agencies that may not. Please reach out directly to the Bureau. But even with a lot of our small rural partners, they did still have jurisdictional email addresses to utilize for that.
Is there a way for us to look at just the outcome information for just Utstein criteria patients?
There may be a way, but I don't know, Allison.
And if we can go on the summary page. All right, and if you go down and in the Shelley, if you want to select the Utstein population and select it, yes, select all and then just select yes. First do the select all and then select yes. Yeah. No.
You select all and then
Just the yes, that's it. And then it will show you the patient final outcome for 461 population. So that's a 20% survival rate in population. And
Thank you
also,
so much.
yeah, and also if you can go on the last page, final outcome.
I'll be right there.
Over there, we have, if we select on esteemed population, yes, not the no. If we select on the yes, and then it's over there, it will change your graph and then it will show you the survival.
Oh, perfect. Okay, thank you so much, Vatsal.
Yeah, I mean, all these graphs are changing. So if we, like, for example, the response time, can we select the response time, maybe 13 to 15 minutes? Graph, and then it will show the, look at the survival decrease to 2.6%. So these, all the graphs, we can select it to see the effect on, the effect of it on the survivors.
Yeah. And okay. So thank you, Vatsal, for pointing that out. If you can click on 0 to 4 minutes, we'll kind of go down the response times. So if you see 0 to 4 minutes, you have 6.6% survival, 5 to 8 minutes, 6.3%. So a little drop, but not as big. Go to 9 to 12 minutes. Now you're down to 4.6. So that's a pretty sizable drop in survival. And then once you hit that 13-minute mark, you see significant drop off in survival rates.
Thanks, Adam, Gail, Vatsal. There's a question in the chat from Dr. Rice. Does the Utstein population include bystander CPR provided? I know frequently Utstein is defined as shockable initial rhythm and bystander CPR.
So can we go to the summary again page, Adam? Oh, sorry, Shelley. Yeah, and then if that Utstein population, there is a question mark. Do you see that kind of information, not the question mark? Now, left-hand side, yeah. A Utstein case is a witnessed arrest in a shockable rhythm without a DNR. That's the definition. Is that the definition we are looking for?
Yeah, I would just, in the old reports and in, if you look at some of the CARES reports, there's two separate Utstein definitions, one that includes bystander CPR provided and one that does not include bystander CPR provided. I just wanted to clarify which Utstein criteria you were using.
Right. This is the definition we have used. If there is any other suggestions we would like to change, I mean, let me know, but that's the current definition.
Thank you.
And we're certainly open if you feel that it would be beneficial. There's a little bit of variation, as mentioned, in terms of how the Utstein is defined. And so if the, if that's feedback, that's certainly something that we have the ability to adjust those definitions as well.
Thanks, Gail.
One other question / suggestion for the future, realize you can't do this now. It would be very cool to have a year-over-year comparison, some type of graph that would do 2024 to 2025. That type of information could be very interesting also for system leaders to look at. So
definitely, Dr. Gaither, that is my plan, but I currently, because we are looking for 2023 and 2024 data, this 2 years, once we add third year will come, we can definitely include some graphs which shows the trend analysis.
Great. Any other questions, comments, suggestions? All right. Perfect. Thank you for that update and all your hard work. Amazing. I think we have now made it to item F, the data quality and data snapshot reports. Ann?
Good morning, everyone. All right, we're going to see how my luck is with sharing the correct window of my screen. So if not, I have emailed this to Shelley, so hopefully, fingers crossed. All right, you can see it. Now let's see if I can actually advance my slides. Maybe. Yay. Okay. I think that's like one of the first times it's worked. I had to Google how you do it with multiple screens. I'm kind of excited. All right. So I wanted to highlight a couple reports that agencies should be getting. And if you're an agency and you're not getting these, then please let me know. Hopefully somebody at your agency is. So we've had a lot of data quality reports go out automatically from the AZ Peer system in the past, but they were individual reports. There were quite a few emails. There was good information, but I felt like we could do better. And so after working on this for a while, and then I got some feedback, I had some, I guess, beta agencies that kind of gave me feedback specifically on their individual reports. We developed a couple of reports that go out scheduled and automatically. And one is a monthly snapshot report, and then the other ones are some data quality reports, some monthly and some weekly. So I put this in a PowerPoint just to snip the reports. I can show you the actual whole report at the end, and it's a blinded report, but I thought it'd be a little easier than looking at this whole screen of data. So the purpose of these, the snapshot report just kind of looks at data trends and a summary of what happened in the previous 1 month. The data quality reports, its purpose is kind of looking at current data quality issues for the agencies to review and with the goal of resolving them, and hopefully before the next month so they can see how they did. The snapshot report goes out monthly, and it looks at only the last complete month. So like when it went out on the 5th of November, it looked at only the month of October. We have it a little delayed to hopefully leave room for submission that might be a little later or not quite as timely. And then the audience is basically the leadership of the agency and any data reporting contacts. So it doesn't have confidential data in it or anything like that. And it goes out via a scheduled email. So it'll come from like no reply to Administrend. And then Y was kind of just fewer emails, which hopefully means that if you just get a couple, even though it's a longer report, it's something that you're not feeling like you get bombarded with all of these emails. There's a lot of expanded content. It's a lot easier to update because we have one giant report that I can add or take things out of, as opposed to modifying 180 agencies' individual reports, which was cumbersome. And I haven't done this yet, but it could be something that I share within AZ Peer's report writer that could be run on demand with a date range of your choosing based on content rates. So, and I also am happy to have any feedback either on this call or later for ideas to add to the report or remove if you think something's not very helpful. So I'm going to start with the data quality report. So each report, it's specific to the agency, and it contains runs for the last month. So hopefully the agency uses this and goes, that's not right, or that looks right, because we only know what we get. A submission timeliness piece, which, there's the 90th percentile, 95th, median, average, that sort of thing. And it kind of gives an idea of where your agency is falling for the last month as far as timeliness of submission. The guideline, or if you're a licensed agency, the requirement is within 48 hours of unit notified by dispatch date time to have a successful submission. Obviously there's going to be hiccups here and there, but that's one reason we have the median and the average and all that on here. And then there's a little separate graph below, or chart below it, that is in red, that just shows how many EPCRs for that agency were submitted in greater than 48 hours that last month. So let's see. And then there's also some validation information on there. So it gives a breakdown of the median, the average, and then like a range with a frequency of the validation for the EPCRs in the last month. And then just some separate little, I call them stoplights. There's probably another term for them, where it just kind of says, hey, anything with a 70, less than a 75, so a 74 or less score, this is how many of your total that was within that range. And then we did 75 to 94, and it's kind of a yellow. I can make it yellower, I guess. And then a 95 to 100, which is, I think, would agree, a good score. And those are kind of just arbitrarily set up. They weren't set up by any particular program that we're doing, but just kind of what I've seen as far as information that has enough information on it to be usable. And then you guys have seen this probably before when I presented on the cardiac arrest report that gets sent out for data quality, but it's the same kind of idea. It is for the previous month. Any business rules, validation rule that was triggered. It gives information on the rule, the number of points it was worth, and then how many incidents in the last month triggered that rule. For the monthly report, this is all that's contained. There's also a weekly version of this report that contains all the same information, but in addition to this, and it only looks back at the last 1 week. In addition to this, it sends out either a CSV or an addition PDF to this report. If it gets too long, the PDF gets cut off. So if you're a larger agency, generally you're going to get a separate email with a CSV that gives example incident numbers. So that 119 in this example that violated Rule 1946, those incident numbers would be contained in a CSV file. I'm not expecting you to look them all up. I can't just do the top 10 examples, or I would, but those are ones that you can use, look in your system, see what the problem is. If you don't see a problem, then that's half of the solution. We can see what's going on. Is there an issue with the data being sent differently, or, you know, whatever. So that is basically the data quality report. I'm going to move on to the snapshot report after this, but I just wanted to. And then the snapshot report is more of like an overview of overall trends. It also honestly focuses an additional data quality report. The first two items on that report are exactly the same as would be on the data quality report, but it's just a nice reference to have on the same report because it's one giant PDF that goes all the way down. So you don't have to go back to a different report to figure out what your total numbers were. And then we just have some various, so this is just some frequencies. Type of service requested was one of them, and it gives a breakdown of all of the types of service requested that were submitted by the agency, so for each call, and the total percent that makes up of those calls. This is something else too, though, that if your agency doesn't do hospital transfers and you have two on there, that might be something we could look into, because I mean, there could be some weird situation, but it also might be something that's not being sent over correctly. I've had discussions with vendors where they have sometimes algorithms set up that kind of guess what kind of call it is. And so you definitely want to keep an eye on that kind of stuff. Cardiac arrest is just the number of cardiac arrests for the previous month. This is something also where if it doesn't look right, in addition to, even if you're not a premier EMS agency, so you're not getting that additional cardiac arrest report that is data quality, you'll see this, and if this does not look right, then this is definitely something we want to address. But as far as we know, there were 6 for this agency. Then there's a segment that kind of talks about transfer care and transports by the agency that's receiving this report. So once again, this is for the previous full month, and this particular example agency only had one instance where they indicated, so with the transfer of care, how this one's defined, and you don't have to read through the whole thing, but these little definitions are actually on the report. So it's right there for you to reference. What does that mean? It is where the agency indicated in the crew disposition, there was patient contact, and in the crew disposition, they indicated that they either initiated primary care, oh, there's a typo there, and transferred to another agency, or initiated primary care and transferred to another EMS crew, or initiated primary care and transferred to another provider on scene. So if any of those were the values submitted and there was patient contact, then they're saying that there was a transfer of care to another EMS agency. This is not a transfer of care to a destination. And then same thing with the EMS transports. It's defined as if there was patient contact and the transport disposition data element was filled in saying that either you have someone participating in the transport, you rode along with someone else, you were the primary crew that someone rode along with you, or you were the only one that transported, but a transport occurred and you were involved in that transport. And then it breaks it down by the transport disposition. So how many were ones where you said this is only your crew, and how many were you with a member of someone else's crew that hopped on. And then the reasons, there's a section about refusals. I feel like this might be something we can improve on, but as far as how it's laid out in the report, but this is also if a patient contact was made and then the patient either was listed as refused evaluation and care, or refused one or the other of evaluation or care. So at some point you indicated that the patient refused care. And then it's a multi-select. The numbers are not going to necessarily add up because you could have like 6 things if you wanted to document them. But it kind of just gives a general idea of, for those EPCRs, what were the refusals listed? And for the transport.
And this is Dale. So one of the things when I look at this, I think there's an opportunity to potentially give some feedback to NEMSIS, because I think for agencies and the individuals in the field, when I look at a lot of these definitions, it's really hard to figure out if these are being accurately selected, or if someone's just trying to figure out, like, what do I click on to get this chart to close? It's a little bit, there's a lot of duplicate, kind of, they mean the same things. And I don't know what, release following protocol guidelines is under both refusal of care and transport, but really you're always going to be following your guidelines, right? So shouldn't that be 100% of the time? I just think there's some opportunities. Maybe, I know these come from NEMSIS at a kind of national level, and then we adopt those at the state. But I don't know if anyone else online kind of looks at these and feels like there's maybe a lot of duplicate or kind of confusing options for the person in the field trying to select.
I can speak for up in Mojave County. We totally agree with that.
Yeah, and that's definitely something I could take back to the Data Managers Council. This is one of those core data elements that the original one in the older version, if you guys remember, it was patient/incident disposition. It was disposition.12. It was divided into 4 to 5 separate ones. The thing about the refusals is it's one data element. So it's just reasons for refusal. So in this case, I limited the first chart to just if it said refused evaluation and care. In the second one, I didn't exclude the ones that said, and that's what I'm wondering if I should change. I did not exclude the EPCRs that said refused evaluation. We only looked at if the transport disposition said the patient refused transport and care. And so this could include, if for some reason an agency documents refused transport, refused care, and refused evaluation, it's going to come up in both of these. And I don't know if it'd be better to exclude in the transport refusals anyone who, any EPCR where it was already indicated they refused care. Because you're right, you can't, the refusal data element is just one data element. It doesn't say whether or not the refusal relates to the transport or if the refusal relates to the evaluation and care. So there can be some overlap, and it's only required to fill out, well, required by us to fill out when you do indicate there is a refusal. But yeah, I also, I can see what you're saying also with the values can be a little bit of an overlap. So I think that'd be a good discussion to have and see what we can do. If the next version, 3.5.1 that's coming out is already set, but we're already starting discussions for 3.6. So this could be something, and that would be a major change if something happened to this particular data element. So I think that'd be a good discussion to start having soon so we could get that in. Thank you. Why does it want to go big? Okay. Some other information, the next 2 slides are kind of related. So just kind of a general area of scene. So in this case, one thing that you can get for feedback is this particular agency 22 times did not indicate, and this is when there is patient contact. So that they didn't get to the scene. So patient contact indicates there was a scene. If there wasn't a scene, then I could see what would be blank, but they didn't put the state or the county or the city. And city kind of makes sense sometimes, but the county and the state should be in there. Even if you're responding in a different state, it is something that, you can fill in. It's not just Arizona. So that's something that kind of doubles as a data quality report. And then for the second part of it, it just shows, okay, these are Arizona. This is, Cactus County. And then the different cities, and sometimes it's the nearest city. That's actually how it's defined by NEMSIS. I understand why agencies sometimes don't want to put in the nearest city because if they're running their own data and they want to see if they're in a rural area, and that's fine. But we do look for it because it's something that's required nationally. So. And then the second part of kind of that, and sorry, does someone have a question? Or
I'm just muting someone.
Okay. Sorry, I just want to make sure because I tend to talk fast and sometimes I don't breathe in between and people have questions. So I didn't put this entire thing in there, so it's actually longer, but this is the scene incident location type. Someone earlier was asking about, oh gosh, I think it was related to cardiac arrest, the location of the scene. And so this is something that gives a general location. It is over 100%. So this would continue on for quite a while of all the EPCRs. So we have single family house, apartment, nursing home. And this kind of makes sense. Sometimes you get some unusual ones, and it depends on how much someone broke it down. But these are standard values. So, and this is only for 911. We didn't include interfacility for this one.
And I do think this is helpful because a lot of times agencies are trying to figure out how often are they responding to care facilities. For this agency, you know, they're responding onto a military base. So obviously, depending on where that jurisdiction is, then you have things like schools on here. So if you're looking to see how often are you responding to schools. So sometimes when people want data within an area, this can be very helpful, looking at how you kind of qualify and quantify what types of areas your crews are responding to.
And it's also something too that if you are in leadership and you look at this and you're like, yeah, that would be a great thing to show, I don't know, our city council or whatever you want to use it for. Obviously, if people aren't filling this in specifically, and no matter what it is, they're putting unspecified school, but you really want to know high school, middle school, you know, that's something that you can talk to your crew trainers about is kind of the importance of getting that information, because it definitely is something that I think I've used and most other people who've analyzed data, we get these kind of questions, especially was it a school, you know, those kind of things. And then we have a couple top 10 lists. The top one was actually added at the request of an agency through some of that feedback as the top 10 dispatch reasons, also limited to 911 only, or rather immediate response in service areas, what it's called now. And it just gives the top 10. So this is, the percents are out of 100%, but it's not going to add up to be 100 here because it's only giving you the top 10. But the percent is calculated based on how many ever you have total, limited to 911. So, you know, falls makes sense, sick person, breathing problem. And once again, if this is usually something that comes over from CAD, but there's a CAD integration, but, and I don't know a ton about dispatch and CAD integrations, but if it looks strange or it, you know, this is something that you can either use or you can see about troubleshooting. And then the second one is the top 10 primary impressions. So it doesn't include if you put it as a secondary impression, and it, you know, it's not the symptoms, but it is also just the 911 with patient treated and transported. So this could be altered, but right now it's only looking at patients that were 911, they were treated, and they were transported. Because that tends to be, I think, more of the ones that you're going to have an actual impression that's not no apparent illness or injury, which is still on here, and that's fine too. That's a valid thing. But it also gives the percent of the top 10 out of the total number. So this is not going to add up to 100. And these are both the full, yeah, I think these are both the full list. I didn't have to truncate these to fit them on the slide.
And quick question, maybe to get some feedback from the group online and in the room, for top 10 primary impressions, do you think it would be helpful to know what your just top 10, not limiting it to those that are transported? Because for some areas, they may have a much smaller percent that are transported, and especially looking at fall injuries. I just wanted to kind of get feedback from the group to see what the group feels. Would it be helpful to look at this as all patients versus just your patients who are transported?
And we could do both too, just as an option if it's not, if you decide we want one that shows the transported and one that shows treated without transported, we could actually do both as an option. But I would love to hear, because honestly, this report is for the agencies. I mean, it helps us too, but if it's not something that's useful, then there's no point in having it, because it's really meant to give them back some information.
I think personally, I think it would be useful just to know top 10 primary impressions in general for all calls, as opposed to just transports, because the reality is that the crews that are responding, they're out of service the entire time they're on a call. So there's a few head shakes in the room, hard to read the online room, but at least for those in the room, there's some head shakes that would be helpful to have kind of top 10 for all
Okay.
patients. Not just
Would you want to include in that top 10 patients that refused care? or only ones where they were evaluated? Like what's the, or we can talk about this offline too, but
I think all comers, just all patients.
just all patients as long as there was patient contact.
Yes.
Okay, yeah, you can do that. Okay, and then I think we just have 2 slides left. So this one, this is, I cut this off. This is a very long one and it would never fit on the slide. So there is a medications given. It excludes anything that was listed as prior to arrival medication. So if they put medication was administered prior to arrival, yes, that was excluded. If they left it blank, it was included because I don't know. And obviously if it was no, it was included. So if it's not prior to arrival, the assumption kind of is that the agency who's reporting gave it. I realize that's not 100% always what it is, but it's generally. And so this is the entire list of medications. I only took the top, whatever, so that we could actually see it on the screen. And it is in order of most to least documented. If for some reason you're documenting it twice, it will actually be on here twice. But and it also gives those little numbers next to it are actually the RX norm codes. That's included because if you want to go to your vendor, this has happened before with procedures where someone's like, that isn't something that we do. That's not something we do at all. But that's what code we're getting from your agency. So if that's not something you do, that's definitely a way that this can also be used as a data quality report. Like if you, I don't know, if you don't give Zofran ever, then you're telling us, though, you're sending us that code 22 times. And that's something we definitely want to address.
So there's a question in the room from Matt Shaw.
I'm curious, we saw this
as well, where ipratropium was listed really high above albuterol.
Sorry, I got the first part, something.
We saw this on this when we looked at like all the state medications given as well. Ipratropium was above albuterol. And again, it's on this list where ipratropium is listed as one of the top medicines, but not albuterol. It seems weird that that would be the case, right? Like we don't typically give one without the other. And if anything, we give more albuterol than we give ipratropium. So
This one is albuterol 21, and I can't say it, ipratropium 20. So you're saying that doesn't?
It's still, you would think that there'd be a higher number of albuterol versus ipratropium is what he's saying. So
It could be that, I mean, this is what this particular example agency, this is what we're getting. So this is a great conversation. If you're looking at this and it doesn't make sense, then that's something we can dig into and see if, especially since if this is counting, multiple times you're giving it per patient, because so it's not going to say add up to the number of patients you have because you give them more than one medication. Is there something that is not coming over all of those times? Is it just getting documented once, even though there's multiple applications or whatever? And then we can also look to see if there's something going on with the way that I calculated it. So yeah, that's a good thing to get from this report. And then the procedure is the exact same concept. It actually lists everything, but I don't have room for that on the slide. And it also it doesn't give the ICD-10 codes, but it does give a code as a reference so that we can go back and see if there is an issue. Like I said, there's some good examples with when we find stuff that's gone wrong. Luckily, that doesn't seem to be on here, but for some reason, if you do not do, I don't know why you would do an IV insertion, but if you just don't as an agency and you're like, what is that? Or if it says something weird like chemical sedation, you're like, why are we chemically sedating almost all of our patients? There's probably a wrong code that's being sent, but that is the code that comes over. So if you labeled something, we do not get the label. We get the code, and it just knows what the code is based on, it translates back to an ICD-10 code or a SNOMED code, but and I really encourage you guys to look at this, honestly, because we did have more than once this problem where for months we were getting something that apparently the agency wasn't doing. And the only way we found out was when the hospitals thought that something looked really weird because it was out of scope. So, because that's the information we were getting from the agency. And then the last part of that report, the snapshot report still, is it's destination types, so hospital, landing zone, assisted living, whatever, broken down by type of service requested. So if you only do emergency response, primary response area, which it used to be called 911, then you're not going to have the other types of service listed, unless, of course, once again, something's weird and it's on there and it shouldn't be. And then within that, it's broken down in order of the place you go the most. And so it would make sense. Emergency department, landing zone, assisted living. This is the destination, not the scene. I don't know why there would be a 911 call that would go to an assisted living as the destination, but that probably is a data entry error, and that's something that we could look into. It's just, you know, it's the weird stuff too that kind of sticks out, but it also gives you a general overall idea. And then lastly, select destinations. And what I mean by that is we limited the destination listed here to only certain types. So if the destination type, which is why the destination type is so important, it's hospital ED, freestanding ED, hospital bed, behavioral mental health, or drug alcohol rehab, then and it excludes anything where your agency said there was not a transport or non-patient transport. If those two conflict, it's not going to show up in here. So that's something to, like you say there wasn't a transport, but then you give me a destination. There's a validation rule that should trigger at that, but it would exclude it from this also. And it's in order of the places you go the most, the least. And this is something else that if you guys wanted on your report to see, to have it not limited by destination type, we could do that. We could just say, I don't care if the destination is, we could include assisted livings or whatever. So all of these things can be varied. And that is it. Thank you.
Excellent. Thank you, Anne. Any questions regarding the data report? All right, hearing none, we're going to move on to the stab report review. Vatsal.
Sorry, can I share my screen because I have added a couple of tables based on the request from the staff. All right. So the trauma, the STAB report is, I already presented this thing into the STAB meeting, so I'm not going to go over the entire report, but there were a couple of requests made during the STAB meeting, and I will show those data in the end. But just to give you an overview, again, we have a data available from 2017 onwards over here. This is almost what right now. Oh, that's cannot hear me.
Much better. Yes, thank you.
Okay, so this tab report over here, we have data available from 2017 to 2024 now. Pretty soon, I think, once we have 10 years of data available, we are ready to do a 10-year trend analysis. And we can create at that time maybe a new report, or we can include some trend analysis in the existing report. But what it says over here in the snapshot, 2024, we have around 74,000 trauma incidents, which basically leads to average of 204 trauma incidents per day. And the total number of hospitals submitting data is 47 in 2024. 8.9% pediatric population and 46%, almost half of our trauma incidents is a geriatric populations. And that again makes sense is because fall is our #1 mechanism of injury. 2.2% mortality. The mortality in the state of Arizona has been pretty static. We are in this range since last 10 years, I would say. 1.1% in pediatric and 2.3% in geriatric patients. These are the top 5 mechanisms of injury and trauma fatality reasons. Top 5, we can choose the geriatric or pediatric populations, and it will show us for each of the populations what is the top 5 mechanisms for and the mechanisms for fatality. Hospital charges are given 5 and it gets divided by the type of insurance, and then also the snapshot also talks about some of the protective factors, opportunities for injury prevention. So for example, for motor vehicle occupant trauma, we had a 72% seatbelt use, and if we see the seatbelt use, in the seatbelt population, fatality is 1.2%, whereas in no seatbelt, the fatality is 3.78. So that's an obvious, we are like in this 70% seatbelt use, I'm seeing it since last many years. It goes up and down a little bit, like 1% here and there, but we are stagnant. There is no increase in seatbelt use over the last 10 years now anymore. It's 72, 73%, and it stays there. Motorcyclist trauma, helmet use, 65% used helmet. Again, if you look at the helmet group and no helmet group, the no helmet group has a higher fatality and a way higher head injury rates. Similarly, in the pedal cyclist trauma, the helmet use is really low compared to motorcyclists. It's only 34%. And again, in the no helmet group, the fatality is 2% and head injury is 13% compared to 7% in the helmet group. So these are some of the ideas. We are trying to present it over here in the annual report, the way, that how do we look at the annual report, or how do we look at our data to get some idea regarding the injury prevention efforts. Then we have many tabs available: demographics and county level, gender, age, specific population. So what each of the tabs says is that the demographics is pretty straightforward. It talks about the trauma rates over the years, and then the race, ethnicity, age, gender, and county distribution for the trauma. And then at the county level, what you can see is this basically gives you an overall, because we can select any of the county. Right now, because I haven't selected any county, it is a statewide picture. So it gives me all the mechanisms of injury, then alcohol, drug use, hospital charges, and what is a fatality and in the state of Arizona. But if I select county, for example, the red color suggests that it has a very high trauma rates. So let me select La Paz, which has the rate is 2,000 plus. And if I select this La Paz County, it will give you in La Paz County, okay, what is the #1 mechanism of injury and what is the fatality and drug and alcohol use and things like that. Now, if I choose another county, like this is our Gila County, and then it tells me, okay, there are more falls in Gila County, but the La Paz does not seem to have a fall as that much as Gila. If I select maybe Apache County, then it again gives me a different picture. Maybe the age distribution is different in this county. Maybe the alcohol consumption. As you can see, the alcohol consumption is little higher in Apache County compared to what we saw in La Paz County. So these kind of comparisons, we should be able to do it at the county level on this page. So each of these page kind of does the similar thing. So if we look at the gender specific population here, again, this is because none of the gender is selected. This will give you a statewide picture. And as soon as you click on the gender, like the female, and this is everything about female population or the male populations, and it will show you different data. Age specific. Now this page will give us pediatric and geriatric 2 options. By default, the pediatric population has been selected. This can give us the top 10 mechanisms of injury in the pediatric population. What is the alcohol, drug? What are the total charges, gender, county, level informations, and everything. Level 1 trauma, this page is specific to just level 1 trauma incidents. And we saw that we have some 70,000 plus cases overall, whereas the level 1, 51,000 came from the level 1 trauma centers. And the county map looks a little different compared to what we saw statewide. If we see, most of our rural counties are red in color compared to the urban counties. Then this page is top 6 mechanisms of injury. So we have the options over here to choose top 6 one of the mechanisms of injury by default I have kept for over here because that's a number 1 mechanism of injury, but we can choose any of these injury and it will show you what is happening in this. So if I choose the motorcyclist, and then it will give me the trends in the motorcycle injury, which is kind of, we are saying it's just increasing over the years, which population it is affecting more, like more among white followed by black population. It's 100% it is unintentional injury. 40% alcohol and drugs, so way higher compared to the statewide. Then age and gender, obviously more among males and 18 to 24 males. And then the county-wide, which county has more motorcyclist injury compared to other counties, that information you can get it from here. This is a page which is not available on our website. This was requested last staff meeting when I presented the report. It was about, they wanted to see the age distribution specific among suspected or confirmed drug use and alcohol use populations, and also the age and gender distribution they wanted to see in e-bike injuries. So what you can see over here, this the first is age, drug use, and age-specific trauma incidents. And it kind of tells us we have like 15 to 17 years old, it's like 3%, and it increases, and then it's kind of decreasing. So mainly is this age group 18 to 44 years old is the drug use. And similar pattern we see in the alcohol use also. It's this 18 to 44 years old. It's the highest alcohol use and the drug use. The gender-wise, it is more male, be it a drug or alcohol. 70% is male, 30% females. Now for the e-bike, what we found, we have the variable, the data we collect in the registry which asks for the e-bike is a position in the vehicle, and we have one of the option is e-bike. Now how complete this data is, it is difficult to see. I don't know. I don't know how often it gets picked up, or are they really using it correctly? That data quality, we still have to do a research on that. But currently what it shows is that we have 375 e-bike injuries. That is in a year. So it's like once every day there is someone is getting really injured bad, which go, that we have to take them to the trauma center. So e-bike injuries, this 0 to 14 has the highest e-bike injuries. So of the 360 trauma incidents happened among 0 to 14 years old. And again, 80% male compared to 20% female. So that is an overview of the STEM. If you guys have any questions or would like to see any further details, open for the suggestions.
Thank you, Vatsal. I see someone with their hand raised. I don't know who it is.
Hi, Vatsal. It's Sean from Flagstaff. I love this report. And I also am very interested in looking at e-scooter injuries. Being right next to a college campus, we are just seeing tons of e-scooters, and we're seeing fatalities, severe head injuries, etc. And honestly, we're seeing more e-scooter injuries than we are e-bike injuries. So I'm just curious if from Anne's perspective and from Carissa's perspective, if there's been education to the trauma registrars about exactly how to capture that data and to ensure we've got good data quality, and then to see also if we could maybe get a report on e-scooters.
I think I can address part of that question. This is Anne.
Actually, not to interrupt, but I think that is our next agenda item. And in the interest of time, we have 4 minutes left. Anne, could you summarize the next agenda item in 2 minutes or less, the discussion on e-scooter, e-bike data?
Yes, I think so. So, at the last trauma registry users group, I know Chris is out on maternity leave right now. I know she discussed with the trauma registrars updating the codes to more specific codes that were available fairly recently for the cause of injury codes. So they were not as specific before the codes available. And the same thing with the EMS users group in October is we recommended that agencies update their pick lists, because you can put various options on your pick list out of the total number, which is huge. And to move to those codes so that we could specifically start tracking it a little more successfully, because the previous codes weren't as specific as to whether or not it was an e-bike versus an e-scooter or whatever. And so the newer codes, it basically is, I think the trauma registrars are going to be tracking this fairly accurately. I think EMS, as long as they add the new codes, but we'll have to see how this goes once they've added the new ones. But it is in there. It's just it doesn't differentiate between the two the way the older codes are. I don't know if that's what you were looking for, but.
Thank you, Ann. I believe, just to clarify, I don't think there's any action item for agenda item H. Is that correct? This is just simple notification that they're updating the e-codes and e-bike codes for trauma registry documentation. Is that correct?
Yes, and I have, it's in our meeting minutes from EMSRUG, and it's something that'll come out nationally, I think, in 2026. We just haven't had the discussion yet. But yeah, both groups were recommended to pick up the new codes, and they both voted to pick up the new codes. So we just need people to actually, because the old codes aren't wrong, so we're not going to stop using it. Just we want, if it is this type of incident, we want the more specific codes added so that can be specifically documented.
Perfect. Thank you for that update. Any other questions regarding the STAB report or the updated e-codes? If not, thank you for the brief update there. We have made it on time. If you do have an agenda item for consideration at the next meeting, please forward that on to Shelley. We will do a brief call to the public. Anybody have items for the call to the public? Okay, hearing none, please see the list of upcoming events in the agenda, and note that our next meeting will be in 2026. Enjoy the holiday season, and we will see you all in March. Thanks, everybody. Have a great afternoon.
Thank you.